Hello and welcome to my Opthal teacher. The last lecture in the series on diabetic retinopathy was on imaging and certain biomarkers on imaging and part one of treatment, that is the role of PRP in diabetic retinopathy. So we will be proceeding with the treatment in two more parts, and that is two more lectures and the topic will be covered. So this is how the therapy or the treatment for diabetic macular edema. We discussed PDR treatment in the last slide. So this one's basically about diabetic macular edema. So this is how the treatment has evolved over time. So you see in 1985, the laser treatment was first tried. And then triamcinolone came, which is basically a corticosteroid. This was followed by the ETDRS protocol, laying down its own criteria for laser photocoagulation, and in the year 2010 the first anti-VEGF was introduced, and then the entire scene of treatment of diabetic macular edema was revolutionized, right? So before 2010 was the era of laser photocoagulation and the era of ETDRS, right? And it was mostly the laser being the gold standard of treatment. With the introduction of 2010, now largely anti-VEGFs have superseded the lasers, and they are now the gold standard of treatment of diabetic macular edema in most situations. This is an important slide. Undergraduates should please note. Before developing anti-VEGF or DME, as I told you, the standard treatment for CSME or clinically significant macular edema was macular laser photocoagulation, since the ETDRS was published in 1985. So when the anti-VEGFs were introduced, they were obviously compared with the existing gold standard, that is laser, and all the anti-VEGFs showed a clear superiority over the lasers, right? So we'll be seeing how, and that is why anti-VEGFs have superseded lasers in the treatment of diabetic macular edema. Now, will you treat all cases of diabetic macular edema? Treatment is typically indicated if center involving. We've seen the definition of CSME as well as CIDME. I think you can go back to my slides on imaging and treatment so as to define the diabetic macular edema based on the OCT, FFA. You can just go back and revise. So treatment typically indicated if center involving and affecting the visual acuity. Preferable to initiate diabetic macular edema treatment before scatter laser and prior to cataract surgery. Scatter laser was the term given to PRP in the ETDRS trials. So if the patient is going to undergo cataract surgery, it is better to start the DME treatment before that, because cataract surgery often worsens any existing diabetic macular edema. There was this protocol, DRCR protocol V, which states that eyes with center involving DME. So the first criteria, center involving DME, but visual acuity better than 20 by 25. Observation with close follow-up may be reasonable and does not compromise visual outcomes at 2 years. So basically, these people, they evaluated patients of center involving diabetic macular edema with good visual acuity. And they said that if a close follow-up can be maintained for such patients, one can skip anti-VEGFs and simply observe the patient, provided close follow-up is done. So this showed that there was no compromise in the visual outcomes at 2 years, as long as the visual acuity remained better than 20/25 and there was no further increase in the edema. Okay, so this is just a picture showing the classical CME or cystoid macular edema pattern of edema, okay, and with some spongiform edema on the side. Now, a general treatment algorithm for diabetic macular edema. So, depending on whether it is non-center involved, center involved, with proliferative changes, and with VMT stands for vitreomacular traction, and ERM is epiretinal membrane. So, non-center involved, one can either observe as according to the protocol V, or one can do focal laser. Focal laser was the treatment of choice in the ETDRS era. So this is about non-center involved. So today somebody might want to closely follow up this patient or might wanna inject. Focal lasers are rare. Then coming on to center involved, once the diabetic macular edema is center involved, you look at the visual acuity. If it is good, close follow-up, protocol V, right? Or poor visual acuity, intravitreal anti-VEGF. There is no thinking about it. Intravitreal anti-VEGF, center involved DME with visual acuity less than 6, with visual acuity poorer than 6/9. This is a no-brainer, okay? Just inject. Then with PDR, one can do monotherapy with intravitreal anti-VEGF. Now, monotherapy or only anti-VEGFs have proven themselves to be as good as PRP in some recent trials. So one can inject monotherapy followed by re-evaluation for PRP once the macular edema resolved. So macular edema is worsened by cataract surgery. It is also worsened by PRP or panretinal photocoagulation. So it is advisable to treat the existing macular edema first and then go for these two things. And of course, if there is a traction on the retina or there is an epiretinal membrane, one has to consider PPV or pars plana vitrectomy. Just some snippets. Monthly monitoring with OCT is a must whenever you are injecting. The average number of injections is 8 to 10 in the first year, and then it decreases 2 to 3 in second year, 1 to 3 third year, 0 to 1 in the fourth, fifth year of treatment. So it's gonna take 4-5 years or more, and it's gonna take so many injections, and mind you, these injections are costly. So the second line I've just put here to emphasize on the treatment burden when it comes to anti-VEGFs for repeated anti-VEGF injections for diabetic macular edema. Then aflibercept provides the best visual outcomes over a period of 1 year, especially with those having worse baseline visual acuity. Those with poor vision at the outset performed better with aflibercept, but this performance was valid only for a period of 1 year. At 2 years, all the groups were comparable, mostly ranibizumab. If the DME is persistent, consider laser treatment after 24 weeks or intravitreal triamcinolone, especially in pseudophakic eyes. We'll be discussing all of these points in details subsequently. So let us talk about laser treatment for DME. We still need to talk about focal and grid laser because the ETDRS mentioned it, and many of ETDRS guidelines are still followed and they are still very much valid. So undergraduates, please note, this is important for you also. What the ETDRS meant by focal lesions was microaneurysms, edema, short capillary segments that show focal fluorescein leakage. So focal lesions only between 500 to 3000 from the center of the macula. So we remain 500 microns away from the center of the macula and go up to 3000 microns from the center of the macula. We'll be looking at a diagram subsequently. The size preferably is 50. Duration again 50 milliseconds. Endpoint of treatment is whitening or darkening of the focal lesions. Now, modified ETDRS guidelines recommend focal laser treatment of microaneurysms and grid treatment of diffuse leakage and focal non-perfusion within 2 disc diameters of the center of the macula. Okay, so the modified ETDRS guidelines have been laid down for focal laser treatment of microaneurysms which are within 2 disc diameters, that is within 300 microns of the center of the macula. Yes, the focal laser treatment can be given keeping these settings. And grid treatment of areas of diffuse leakage and focal non-perfusion may be given. These are the modified guidelines. They're not there in the conventional ETDRS guidelines, okay? No laser marks, no laser given to areas within 500 microns from the center of the macula. Again, this is also changed, mild gray burn according to modified ETDRS, okay? Now, the principle of focal laser is that it occludes any leaking microaneurysms in the retina by vascular thrombosis. This is followed by RPE recovery, the stimulation of cytokine production that leads to reabsorption of fluid in the macula, and there is subsequent fibrosis, that is healing, leading to formation of laser scars, which you see here, okay? And here also you see these grayish scars. If you do an FFA, you'll see these scars are like this, okay? Black in the center and hyperfluorescent taking up stain at the periphery. Now, there is evidence, increasing evidence that laser for microaneurysms is not recommended because of risk of central scotomas in the future. Yes, obviously, because if you're going to encroach within this area of the macula, it is going to cause scarring, as a result of which scarring in the central area is going to cause central scotomas. So there is increasing evidence that focal laser is not recommended. Okay, according to both even though ETDRS and the modified ETDRS guidelines recommended it. Okay, so look at these focal laser marks, right? Then coming on to grid laser. Grid laser is for diffuse macular edema, diffuse leakage or capillary loss. Spot size remains the same, mostly 50. Duration is also 50. Grid treatment is not, now this is the conventional ETDRS. Grid treatment is not placed within 500 microns of the center of the macula. Okay, this is the center of the macula. This is the center of the disc. So 500 microns within this, here over here, the ETDRS said that do not place lasers. And in this area, within 500 microns of the center of the disc, do not place lasers. That is what the ETDRS said. But according to the modified guidelines, you see, this is obviously, this has encroached within that 500 micron zone. So the modified guidelines say that, okay, you can do grid laser for diffuse leakage or capillary dropout areas within 2 disc diameters of the center of the macula also. So this somewhere over here is the center of the macula, and this is a modified grid laser that has been done, right? The grid can extend up to 2 disc diameters, 3000 microns from the center of the macula. Now, follow up. So, suppose this was an area of diffuse leakage. Okay. So, you gave a grid laser in this area. So, the spot size is around 50 to 200. You can remember 50. 0.05 to zero point 0.1, or you can say 50 milliseconds duration, 50 micron spot size, 50 milliseconds duration in a grid pattern. Okay, so it's like a grid, one burn width apart. You can also do less than one burn width apart in a tight grid laser, right? Now, how to follow up? New treatment can be carried out at 6-week follow-up visit if it is apparent that treatable lesions have been missed during the initial treatment, and further treatment can be delayed until the next 4-monthly visit and each subsequent 4-monthly follow-up visit. So that was about your grid lasers. Focal laser. So just a summary of the ETDRS protocol for lasers for diabetic macular edema. Focal laser applied directly to microaneurysms in area of retinal thickening between 500 to 3000 microns from the fovea. Okay, you see these tiny green dots over here. That's your focal laser for you. The yellowish are the hard exudate. The yellow lesions are the hard exudates. Okay, so focal green laser spots have been given to these areas. And grid laser applied to areas of retinal thickening or areas of CNP between 500 to 3000 microns from the fovea. So 500, see, no treatment within 500 microns, and 3000. So you see this grid pattern, this semicircular grid-like patterns that extends from 500 to 3000. You should remember the extent, okay, of from the fovea. And what is treated? Areas of retinal thickening versus and areas of CNP. What is treated here? The areas of microaneurysms. Now, you cannot see the microaneurysms. It's not a very good picture, but the very presence of hard exudates means that there are retinal thickenings, and there might be, there will be microaneurysms somewhere over here. Okay, it is only around, these hard exudates usually happen around areas of leakage, right? So the lasers have been applied to the microaneurysms only. Okay, you see these green dots, they have been applied to the microaneurysms, which we cannot see, but the clinician must have visualized. So the results of the laser were as follows. 33% treated with focal or grid photocoagulation improved visual acuity after 2 years. 20% showed reduced visual acuity, and 50% had persistence of central edema at 2 years. Okay, despite the focal or grid laser. Now, intravitreal triamcinolone. So we saw that the treatment of diabetic macular edema began with photocoagulation. Then triamcinolone was introduced, yes, for a brief period. It is still being given in certain special situations, followed by the ETDRS. Okay, and the ETDRS guidelines, and that continued to be the treatment of diabetic macular edema for quite some time, followed by the introduction of anti-VEGFs in 2010. So we've talked about lasers, we've talked about the ETDRS protocol. Now let's briefly talk about triamcinolone. Undergraduates, please note, now you need not remember the studies over here on the left side, that is for the PGs, but you must remember the indications of intravitreal triamcinolone. So we talked about laser, now we'll talk about triamcinolone, and subsequently we'll be moving on to anti-VEGFs. So triamcinolone indications: pseudophakic eyes. Intravitreal triamcinolone plus prompt laser is comparable to ranibizumab in terms of both visual acuity and macular edema. Okay, so this protocol I, okay, it was comparable in terms of both visual acuity and macular edema. That is triamcinolone plus prompt laser comparable to ranibizumab. Therapeutic option in pregnancy or when there is a contraindication to anti-VEGFs, that is recent myocardial infarct or any episode of thromboembolism. Whenever there is a risk of, and of course the side effect is with steroids is that there is a risk of secondary glaucoma and cataract if the eye is a phakic one. Sustained release intravitreal steroid implants are promising. We will be talking about these in the end. So for the postgraduates, just some protocols. I think for protocol B and protocol I of the DRCR, you can remember that protocol B compared focal/grid laser with intravitreal triamcinolone, and it was found that the laser was more effective at 2 years. Protocol I, intravitreal triamcinolone plus laser versus ranibizumab plus laser versus laser alone. So at 2 years, triamcinolone plus laser was inferior to ranibizumab plus laser and laser alone. Okay, so ranibizumab did better. But in pseudophakic eyes, it was comparable. Okay, triamcinolone and laser was comparable to ranibizumab. Then protocol U, ranibizumab plus DEXA implant versus ranibizumab alone, 6 months. They showed that eyes in the combination group, that is people who received dexamethasone implant, the steroid implant, in addition to ranibizumab injections, did not have any added advantage when compared to the people with ranibizumab alone. Okay, so just remember that it is the treatment of choice in cases of persistent DME and in pseudophakic eyes, and in pregnancy or when there is a contraindication to anti-VEGF, and of the records, I would also like to add, in patients who cannot afford. Okay. Now moving on to anti-VEGFs for diabetic macular edema. So the rationale, what is the rationale? Undergraduates, please note, it is important for you also. Then you have to know the mechanism of action of VEGF. So whenever there is hypoxia, we saw how hypoxia happens, right? In diabetic retinopathy, go back to the pathogenesis. So hypoxia induces the production of VEGF. The production of VEGF is in turn is done by retinal endothelial cells, Muller cells, which are the retinal glial cells, retinal pigmentary epithelium, and astrocytes, which are again the retinal glial cells. Okay, so all these 4 types of cells produce something known as VEGF or vascular endothelium growth factor, which incites inflammation and neovascularization, leading to the complications of diabetic macular edema and neovascularization. So the VEGF family. So that was about the VEGF molecule. Okay. So on the left side in this table here are the various types of VEGF molecules. So there is VEGF A, B, C, D. There are several more. I've only showed A, B, C, D here because they are the ones that are implicated in retinal diseases. VEGF-A is the most, one can say notorious one. So A again has several isoforms, of which A165, VEGF-A isoform 165 is the most important. It is the most implicated. VEGF-A acts on both VEGF receptor 1 and receptor 2. So 1, 2, 3, the most important receptors. Now VEGF-3 not so important for us, but VEGF receptor 1 and receptor 2 and the VEGF-A is extremely important. Okay. Now, this is what happens. This is the VEGF-A molecule. This is the VEGF-R1 and R2 receptors. And these red sites over here, these are the VEGF binding sites. Okay. What is VEGF receptor? It is a tyrosine kinase type of receptor. Upon activation, this is the vascular endothelial cells. So this tyrosine kinase type of receptor, upon activation, stimulates angiogenesis and increases vascular permeability, okay, leading to complications of diabetic retinopathy. Now there is one more factor, that is placental growth factor or PLGF. Okay, this also acts on VEGF receptor type 1 and it also stimulates angiogenesis. Okay, so since it is not mentioned in the table, I've cut the table. I have not mentioned it here. I've mentioned it separately here. This is also important, and there are anti-VEGFs which act against both VEGF-A, B and the placental growth factor. So please remember, placental growth factor also, it also behaves just like VEGF-A, stimulating angiogenesis, and it acts on VEGF receptor 1. This is the family. These are the people in the anti-VEGF family. So the first synthetic anti-VEGF was pegatinib, and it is approved for neovascular AMD but not for diabetic retinopathy. So this basically binds only one VEGF-A isoform, that is A165. Okay, so that was pegatinib. Then came the first anti-VEGF used particularly for diabetic retinopathy, but still remains off-label, that is bevacizumab. So this is the structure of the antibody, right? Any antibody for that matter. This is the constant FC and this is the FAB, right? FC, FAB. FAB stands for antibody binding fragment and FC stands for the constant fragment. These fragments are made up of light chains. These are the light chains, the dark brown, and the heavy chains. These inside are the heavy chains, that is the light brown and the silver. So this is what a simple uh, antibody structure looks like. So bevacizumab is basically a recombinant monoclonal antibody which binds all VEGF-A isoforms. Where does the VEGF-A molecule bind? It binds here, okay? So it binds all the VEGF-A isoforms and that is your bevacizumab, used off-label for diabetic retinopathy. And bevacizumab is initially not even used for the diabetic retinopathy. It was approved for colorectal cancers, right? Still being used. That is your bevacizumab. Then came ranibizumab. Now what the scientists did was they extracted only the antigen binding site of bevacizumab here, the antibody fragment, the FAB fragment, okay, and thus this molecule became smaller in size. So ranibizumab binds all VEGF-A isoforms with a higher affinity than bevacizumab, right? And this was introduced in 2006 and this is an FDA approved drug, ranibizumab, right? Next came aflibercept. Aflibercept is a fusion human protein, is a fully human fusion protein. How? It binds the FC portion with an FAB portion. How? The FC portion is the same as the FC portion of the IgG antibody, same as this. But these binding sites are different. Now, what are these binding sites? These binding sites, what do they bind? They bind VEGF-A, VEGF-B and PIGF, right? You remember VEGF-A binds to both VEGF-R1 and R2. Also, there is VEGF-B and PIGF which binds to R1, the receptor R1. So basically, this has the binding sites of VEGF receptor 1 and 2, right? That is why it is a human fusion protein. Why fusion protein? Because it is formed by the fusion of the Fc portion of human IgG with the VEGF receptor 1 plus 2 binding sites, okay, on the FAB. So this is aflibercept. This was introduced in 2011. Following aflibercept, faricimab has also been introduced. It targets VEGF and angiopoietin 2. Please, for the undergraduates, you have to remember this diagram. Okay, this is the least, if it's very good if you remember this. That is the structure of each of these, because they are the, you know, the gold standard now, right? So you have to know about these. When we were reading about the treatment of diabetic macular edema, we would read only about lasers. We did not know anything about anti-VEGF when we were undergraduates like you. But now this is the treatment of choice, and so you have to know about these also. So just a comparison of bevacizumab versus ranibizumab. Okay, the company, the class, this is a full-length antibody. This is just a fragment. Molecular weight 149 versus 48. Half-life 20 days versus 9 days. Licensed indications, licensed by who? By FDA. So bevacizumab is for colorectal cancer, small cell lung cancer, glioblastoma, and metastatic kidney cancer. This one's for wet AMD, DME, macular edema secondary to retinal vein occlusions. Mind you, ranibizumab is much more superior with greater affinity for all isoforms of VEGF-A, because it has more diffusion. Being a smaller molecule, it has more diffusion into the retina and the choroid. That is why ranibizumab was better. Dose, you have to remember the dose also, the postgraduates especially. This is the dose of bevacizumab and this is for ranibizumab. These are the side effects, which are rare by themselves. So again, the mechanism of action, you see, this is, for example, this is bevacizumab, the heavy chain, the light chain, the Fc portion, and the FAB portion. So from here, if you extract the FAB fragment, okay, which is made up of constant and variable portions, both heavy chain as well as light chains. This is the light chain on this side, and this is the heavy chain. So this is the FAB fragment, and this results in formation of ranibizumab, right? So the ranibizumab, basically what it is doing, it is coming here, it is binding this tiny VEGF-A molecule, as a result of which the VEGF-A molecule cannot bind to its own receptors VEGF-R1 and R2, and so angiogenesis does not happen. Okay, so this is just a picture of the ranibizumab, the commercial variety of ranibizumab. Okay, it is marketed as Lucentis. And for the undergraduates, please remember this diagram. Now comes aflibercept. So aflibercept, I told you, recombinant fusion protein of the binding domains of both the receptors fuse with Fc domain of IgG1. It traps the endogenous VEGF molecules over here. Okay, whatever circulating VEGF molecule is there, it traps, because it has the binding sites of both R1 and R2. So it's going to trap everything, VEGF-A, VEGF-B, as well as PIGF. Okay, this is the unique thing about aflibercept, and it traps the endogenous VEGF. So that is why it is also known as VEGF trap, right? FDA approved for neovascular AMD in 2011. FDA approved for diabetic retinopathy in 2015. It comes in two doses, 2 mg per 0.05 ml. 0.05 ml is the amount that we inject, okay? Also available as 8 mg per 0.05 ml, okay? So that is about VEGF. Just some biologics that are used or being tried in the treatment of diabetic macular edema. So you have to know at least these four. The latest is faricimab and brolucizumab. Faricimab is FDA approved for neovascular AMD and in DME in clinical trials for DR. So faricimab or Vabysmo is approved for DME, right? So you have to know this one, and it is in clinical trials for DR. Okay, what is unique about faricimab is that it binds angiopoietin 2 also. Okay, remember aflibercept, what is unique? It binds all isoforms of VEGF A, B, PIGF. Okay, and faricimab VEGF A and angiopoietin 2. So approved for DME. So you have to remember these four. And brolucizumab is still in clinical trials for DME as well as DR. Okay, brolucizumab, right? Then there are several others. There is infliximab, also in clinical studies. Most of these other agents are in clinical studies only. Okay, this is just for your information. Now, side effects and contraindications. These are the ocular side effects: transient rise in IOP, transient floaters, injury to lens zonules and retina, which is negligible if experienced surgeons are giving it, endophthalmitis, rare uveitis, tractional retinal detachment if membranes are present. That is why any fibrovascular traction on the macula or the disc, VEGFs are a contraindication. Okay, because they are going to cause retinal detachment, traction retinal detachment. Systemic side effects: bowel perforation, arterial thromboembolism, MI, stroke, hypertension. That is why these remain contraindications. Okay, even though all these ocular as well as systemic side effects are rare, they are not statistically significant. Contraindications, you have to remember, undergraduates, please note, this slide is important for you. So any fibrovascular proliferation at macula, any active inflammation, known hypersensitivity, uncontrolled hypertension, cardiovascular disease, pregnancy, and lactation. These are the contraindications of anti-VEGFs. So this is all about anti-VEGFs, and in the subsequent lecture, that will be the last part in the series on diabetic retinopathy, I will be talking about the clinical trials important for diabetic retinopathy. So thank you very much for watching. Please continue watching for further info on diabetic retinopathy.